Persistent spinal pain syndrome, or PSPS, is a term introduced in 2021 to replace the outdated and often misleading label of failed back surgery syndrome. This new terminology aims to provide a more holistic and accurate approach to chronic spinal pain, regardless of whether a patient has undergone surgery. By focusing on the underlying mechanisms of pain rather than just anatomical factors or surgical history, PSPS helps clinicians better understand and treat patients suffering from persistent spinal pain. In this video, we'll explore the evolution of PSPS, its classification, and how mechanism-based recommendations are shaping the future of pain management. Term failed back surgery syndrome carried negative connotations and failed to capture the complexity of chronic spinal pain. PSPS was introduced to address these shortcomings. By moving away from a focus solely on surgical outcomes, PSPS recognizes that persistent spinal pain can occur with or without prior surgery. This shift in terminology encourages a more comprehensive evaluation of each patient's pain, considering both biomedical and psychosocial factors. The goal is to improve patient care by using language that reflects the true nature of their condition. PSPS is divided into two main types, Type 1 and Type 2. Type 1 or PSPS-T1 refers to patients who have never had spinal surgery but still experience chronic spinal pain. Type 2 or PSPS-T2 applies to those who have undergone surgery intended to relieve pain but the pain persists or even worsens. This classification helps clinicians tailor treatment strategies more effectively, as the underlying causes and best interventions may differ between these two groups. Importantly, PSPS can affect any level of the spine, not just the lower back. Traditional approaches to diagnosing spinal pain often relied heavily on anatomical findings or surgical history. However, these methods sometimes fail to identify the true source of pain or guide effective treatment. By shifting to a mechanism-based approach, clinicians can better classify pain according to its underlying biological processes. This allows for more precise diagnosis and targeted therapies, potentially improving outcomes for patients with persistent spinal pain. Mechanism-based recommendations are now at the forefront of PSPS management. To assist with mechanism-based diagnosis, the PAMC scale was developed. PAMC stands for Pain Type P, Anatomical Location A, Mechanism M, and Certainty C. This composite approach helps clinicians cluster patients into diagnostic groups based on where the pain is, what is causing it, and how certain they are about the diagnosis. The PAMC scale is similar in concept to the TNM classification used in cancer, providing a structured way to describe and treat persistent spinal pain. Persistent spinal pain can arise from several different mechanisms. These include nociceptive pain, which is caused by actual or threat tissue damage, neuropathic pain resulting from nerve injury or disease, and nociplastic pain, which involves altered pain processing without clear tissue damage. Many patients experience mixed pain where more than one mechanism is involved. Recognizing the dominant pain mechanism is crucial for selecting the most effective treatment. Nociceptive pain is typically caused by damage or inflammation in non-neural tissues, such as muscles, ligaments, or joints. In PSPS, this might be due to conditions like facet joint arthropathy or disc herniation. Nociceptive pain is often intermittent and triggered by movement or mechanical stress. Understanding when nociceptive mechanisms are at play helps guide treatment choices, such as physical therapy, anti-inflammatory medications, or targeted intervention. Neuropathic pain arises from injury or disease affecting the nerves themselves. In PSPS, this can occur after surgery or as a result of nerve compression or damage. Symptoms often include burning, tingling, or shooting pain, sometimes following a specific nerve distribution. Diagnosis may involve clinical testing for sensory or motor changes. Treatments for neuropathic pain may include medications like anticonvulsants, nerve blocks, or neuromodulation techniques such as spinal cord stimulation. Nociplastic pain is a newer concept, describing pain that arises from altered processing in the nervous system without clear evidence of tissue or nerve damage. Central sensitization, where the nervous system becomes more sensitive to pain signals, is a key feature. Patients may experience widespread pain, sensitivity to touch, or pain that seems out of proportion to any injury. Recognizing nociplastic pain is important, as it may respond better to treatments like neuromodulation or cognitive behavioral therapy rather than surgery. Many patients with persistent spinal pain experience a combination of pain mechanisms. For example, someone might have both nociceptive pain from a damaged joint and neuropathic pain from a compressed nerve. This mixed pain can make diagnosis and treatment more challenging, but the PAMC scale helps clinicians identify and address each component. Tailoring therapy to the dominant mechanism, or using a combination of treatments, can improve outcomes. Identifying the anatomical source of pain remains important in PSPS. Common pain generators include the facet joints, intervertebral discs, nerve roots, and muscles like the multifidus. Imaging studies such as MRI or CT scans can help locate structural abnormalities, but these findings must be interpreted in the context of the patient's symptoms and pain mechanisms. Over-reliance on imaging alone can lead to ineffective treatment. While imaging is a valuable tool for identifying structural causes of spinal pain, it should not be the sole basis for diagnosis or treatment decisions. Many people have abnormal findings on imaging without experiencing pain, while others have significant pain with minimal imaging changes. The mechanism-based approach of PSPS encourages clinicians to integrate imaging results with clinical assessment and patient history for a more accurate diagnosis. PAMC scale includes a measure of diagnostic certainty, possible, probable, or definite. This reflects how confident the clinician is in identifying the pain mechanism and source. Certainty can increase as more information is gathered through examination, testing, and response to treatment. This graded approach helps guide treatment decisions and set realistic expectations for patients. For most patients with persistent spinal pain, conservative treatments are the first line of management. These may include physical therapy, medications, lifestyle modifications, and psychological support. Only when these measures fail to provide adequate relief should more invasive options like surgery or neuromodulepin be considered. This stepwise approach helps minimize risks and healthcare costs. Surgery is generally reserved for patients with specific indications, such as progressive neurological deficits or structural lesions that clearly correlate with symptoms. Even then, the outcomes of spinal surgery for pain are variable, with only about 60% of patients achieving meaningful pain relief. Risks and costs are significant, so careful patient selection is essential. The PSBS framework helps identify who is most likely to benefit from surgery. Neuromodulation, such as spinal cord stimulation (SCS), is an increasingly important option for patients with PSBS, especially those who are not candidates for surgery or have persistent pain after surgery. SCS can address multiple pain mechanisms and has shown superior outcomes compared to repeat surgery in some cases. Access to neuromodulation varies by country and insurance coverage, but it is gaining wider acceptance as evidence grows. Radiofrequency ablation is another minimally invasive treatment for certain types of spinal pain, particularly when facet joints are involved. This procedure uses heat to disrupt pain signals from specific nerves. While it can provide significant relief, the effects are often temporary, and repeated treatments may be needed. Patient selection and careful diagnosis are key to achieving good outcomes. Recent research has highlighted the role of multifidus muscle dysfunction in some cases of low back pain. Multifidus nerve stimulation is a novel therapy that targets this specific muscle group, offering relief for patients who may not respond to other treatments. This approach exemplifies the move toward mechanism-based therapies in PSBS, focusing on the underlying cause rather than just symptoms. While the focus of PSBS is on biomedical mechanisms, psychosocial factors also play a significant role in the experience and management of chronic pain. Stress, mood, social support, and coping strategies can all influence pain severity and treatment outcomes. A comprehensive approach to PSBS includes addressing these factors alongside physical treatments. Persistent spinal pain is a major driver of healthcare costs worldwide. In the United States, spinal surgery accounts for a large share of expenditures for low back pain, despite being performed in a small percentage of patients. In the UK, thousands of new PSBS T2 cases each year add significant costs to the healthcare system. Mechanism-based approaches aim to improve outcomes and reduce unnecessary procedures, ultimately saving resources. Development of mechanism-based recommendations for PSBS involved an international task force of pain and neurosurgical specialists. Meetings at major neuromodulation society congresses and online discussions help build consensus on the best ways to classify and treat persistent spinal pain. This collaborative approach ensures that recommendations are relevant and applicable across different healthcare systems. To reach agreement on the new classification and treatment recommendations, the task force used a modified Delphi methodology. This structured process involves rounds of discussion, feedback, and refinement until a majority consensus is achieved. The result is a set of guidelines that reflect the collective expertise and experience of leading clinicians in the field. The SBS is compatible with the International Classification of Diseases, ICD-11, but it is not yet recognized as a distinct code. Instead, it can be mapped to several related codes for spinal disorders and pain syndromes. The PAMC scale and mechanism-based approach may help future revisions of the ICD better capture the complexity of persistent spinal pain, improving research and clinical practice. PAMC scale can be applied to real-world clinical scenarios, helping clinicians describe and categorize different types of persistent spinal pain. For example, a patient with definite neuropathic pain in the arm after neck surgery would be coded as P2A3M1C1. This structured approach aids communication, research, and treatment planning. Despite the advantages of mechanism-based classification, there are barriers to widespread adoption. These include resistance to change, lack of awareness, and differences in healthcare reimbursement systems. Ongoing research, education, and dissemination of the PAMC methodology are needed to encourage its use among clinicians and stakeholders. Standardized, mechanism-based approach to PSBS benefits research by clearly defining patient populations and outcomes. This improves the quality of clinical trials and systematic reviews, making it easier to compare results and develop evidence-based guidelines. Ultimately, this leads to better treatments and improved patient care. As our understanding of pain mechanisms grows, new therapies and diagnostic tools are likely to emerge. The PSBS framework and PAMC scale provide a flexible foundation for incorporating these advances. Ongoing collaboration between clinicians, researchers, and patients will be key to refining and improving the management of persistent spinal pain. At the heart of the PSBS approach is a commitment to patient-centered care. By considering the unique pain mechanisms, anatomical factors, and personal circumstances of each patient, clinicians can develop individualized treatment plans. This not only improves outcomes but also enhances patient satisfaction and quality of life. Summarize, persistent spinal pain syndrome is a modern mechanism-based framework for understanding and treating chronic spinal pain. The PAMC scale helps clinicians classify pain by type, location, mechanism, and certainty, leading to more effective and targeted therapies. By moving beyond outdated terms and focusing on the true nature of pain, PSPS aims to improve both clinical outcomes and patient experiences. Implementation of PSPS and mechanism-based recommendations marks a significant step forward in pain medicine. As more clinicians adopt this approach and research continues, we can expect ongoing improvements in the diagnosis, treatment, and understanding of persistent spinal pain. The ultimate goal is to provide relief and restore function for millions of people worldwide living with chronic spinal pain.